next, we've got Dr. Elisa Salas. Dr. Salas grew up in Philadelphia and first realized her love of pathology at necropsy show and tell rounds at Cornell University, where she obtained her DVM. After 4 years of mixed animal and small animal practice, she jumped at the opportunity to pursue residency at the University of Nebraska. In addition to helping submitting veterinarians at IDEXX, she now also serves as a consultant on the clinical and anatomic pathology boards of the Veterinary Information Network. I'd also like to introduce Dr. Richard Luong. Dr. Luong earned his BBSc at the University of Sydney, Australia. After graduation, he worked as a companion animal veterinarian before starting his career in veterinary anatomic pathology by working at the New South Wales Department of Primary Industries in Australia. He joined a combined training program of the Animal Medical Center, Medical College of Cornell Universities, Memorial Sloan Kettering Cancer Center, and Rockefeller University as an anatomic pathology resident, and then started his career as a pathology manager at IDEXX in 2015. So I'd like to welcome Dr. Richard Luong and Dr. Elisa Salas with their presentation, Lymphovascular.
All right.
Great. Let's go to the first slide, Elisa.
Are you seeing the shared screen here?
Yep.
Looks good. All right.
All right. So yeah, I'm going to start off first and just go over a brief, thing about lymphovascular invasion, or LVI. And so I think most of us were taught that the concept of lymphovascular invasion is a pretty clear histologic measure of malignancy, and whether we're talking about that in terms of aggressive biologic behavior or an implied increased potential for metastasis. I think, when we see it, we go, yep, that's something that's bad. But kind of like most of the things we've talked about, the standardization efforts and presentations thus far, we, the veterinary profession and the pathology profession, we haven't really done a great job to really investigate and to confirm and to prove the validity of this belief in animals. And so in particular, we're kind of really lacking a lot of studies that will specifically investigate the significance of what we're seeing, and does it really mean what we think it means. So when the VCGP started down the road of standardization for LVI, we had to ask ourselves a lot of the same questions, right? Who taught us pathologists how to recognize LVI during our training, right? What does that look like morphologically? Did we all receive the same training information? Did we get it from books, textbooks? Were we looking across the microscope with your mentor and trainers? Were they teaching us the same thing? When we were recognizing it, were we using a best practice or a line practice that we would say, yep, that is what it is, and how do we record that information? And then part of it is, once we saw it, how do we interpret the significance of it, right? Many of us just say, hey, it's there, but how do we know, what should we assign the significance, the prognostic significance of that? And if it's there, where's the source of truth for that? So we need to take all this into account when we started down this road with these initial LVI standardizations. And really, it's in the attempt to really be able to set a great foundation for the future so that we can really compare future oncology studies, particularly when we talk about comparing outcomes from different studies, right? We really just want to standardize that part of it. Next slide. So what we're going to talk about in this is we're going to go over the guidelines, but we're really going to talk about what is and what isn't considered LVI histomorphologically. When we do recognize what we call true lymphovascular invasion, what are the recommended initial criteria to record down these observations? And then that's really what we're going to go through today. So Elisa.
All right. So I'm going to talk about distinguishing true lymphovascular invasion from the mimickers. And there's a number of mimickers that some of us may see in our cases, or maybe have not recognized as such, just as our day-to-day work. And the major ones are retraction artifact, pseudo-vascular invasion, impingement, and then there are a few other mimickers. So the first one is retraction artifact, and this is seen most commonly in epithelial tumors, and it can resemble an embolus in a vascular space. And one thing that we want to make sure that we categorize is that there isn't a true endothelial lining surrounding this, and so that's just true retraction artifact. Another way to evaluate that is to determine whether or not that space is positive for immunohistochemical markers for a vascular space. And so the example on the left is a circumanal gland adenoma, and that looks, if you were just passing at low mag, it's as if that could be an embolus, but it lacks that defined endothelial space. And the one on the right is a canine anal sac apocrine gland adenocarcinoma that, again, is in a space bordered by collagen, lacking an endothelial lining or a vascular space. Another mimicker is pseudo-vascular invasion. Well, what do we mean by that? Pseudo-vascular invasion is some sort of artificial displacement of the tumor cells within a vascular space. And so some of the things that can occur and that have been identified to occur to cause that pseudo-vascular invasion are things such as manipulation at surgery, displacement during growth preparation, or during sectioning, or potentially poorly fixed or fragile tumors. So the one on the left is an example of artifactual displacement of thyroid follicular cells. And so this was a pretty interesting study by Meat and Asa. What they did was they had postmortem nodules of thyroids that they pressed prior to sectioning. And when they pressed it, these were all benign thyroid adenomas. They found emboli within vessels. And one thing that categorized whether or not this is an artifactual displacement of feature is that there's a thick-walled vessel here and an otherwise benign tumor. Another characteristic is that there's a lack of a thrombus here. And also there's pretty much a large space of contiguity away from the tumor, but the main characteristic will be that thick-walled vasculature and lack of thrombus in an otherwise benign mass. Another example is if lymphovascular invasion can be identified in, say, some more fragile tumors, so testicular germ cell tumors. And in this instance, they looked at tumor sectioning between residents and technicians, and then as well looked at fixation. Less experienced residents had more incidence of vascular invasion than the pathology assistants. And then also fixation affected whether or not a more fragile tumor would embolize. And so here in this germ cell tumor, you can see again, there's neoplastic cells lacking a thrombus and an overall thick-walled vessel versus more prolonged fixation. You don't see those little round germ cells infiltrating to that vascular space. And so, as I pointed out, some hints for that is that the tumor in the vessel doesn't conform to the vessel shape. It's just kind of floating in space. They'll be present in dilator or thick-walled vessels. Stroma or vascular structures could potentially be present within a vessel with a tumor, so that'd be your floater. So maybe it was sectioned within it and brought in. If there's necrotic debris within the tumor in the vessel, that could be a potential marker for a floater being brought in. And then also a lack of tinctorial change of the tumor within the vessel would be another indicator of pseudovascular invasion versus true vascular invasion. One thing I see semi-frequently is impingement, where the vessel looks like it's impinging into a vessel wall, but it hasn't penetrated the endothelium. So is it in that vessel? Maybe it's not in that plane of section, or is it out? And so trying to determine that can be a real challenge on whether or not it's that case. And I've had cases where I've wondered about that. And so how to distinguish that is whether or not there's endothelial cells bordering that tumor. So like this drawing, so Taryn's relative deserves a lot of credit for doing these graphical drawings. And so here's that endothelial cell lining this tumor space impinging on that vessel. It could suggest impingement. Another thing to consider is this the potential re-endothelialization of the vessel that was invaded by a tumor? So you had growth factors, if it was there for a prolonged period of time, could you have vasculature that's gone over an impingement? So how do you distinguish between that? What's a good indicator? And a really good indicator is a fibrin thrombus associated with that tumor, because that's considered a high criteria for lymphovascular invasion. And so here are some examples in that thyroid follicular adenoma tumor. Here is a thyroid follicular adenoma impinging on a vessel. And sorry for the quality of this image. This is the best I could get from the paper. There's no lack of there's an endothelial lined vessel, but it's not within the vessel. There's no fibrin thrombus. Then I had my own personal case of a mast cell tumor in a dog. And so here I can see and follow and track that endothelial lining over the vessel, and I didn't see a fibrin thrombus. And so are they pushing, the questions we have to ask ourselves as pathologists as we're looking at this, is it pushing into the lumen? And then if it is there something I can use to distinguish this? And so I want to look for something that's a stringent criterion for invasion. And so is there fibrin elaborated within that vessel, within that tumor? And then finally, other mimickers of lymphovascular invasion. In this study, it was for endometrial cancer, and they had 48 cases that they asked 6 pathologists to review. These cases were selected because they had possible lymphovascular invasion, so they wanted these 6 pathologists to review them to see if they did, and then if they did, how would they grade them? And so these gynecological pathologists looked at this and found a couple of mimickers of lymphovascular invasion within these endometrial tumors. And so here on the left, you can see that these are inflammatory cells rather than endometrial carcinoma cells within this vessel lined by an endothelial space. Over here, this is actually epithelial cells lining this almost vascular looking space. This is a microcyst. And then finally, these are definitely tumor cells, but they're not in a vascular space. This is more a tissue cleft. And so those are other mimickers to be aware of as we evaluate our cases and start looking at criteria for lymphovascular invasion. Richard?
Great. So we'll talk about the standardized criteria that we'll be bringing forth in the initial BCGP guidelines. So next. So hopefully I can guess based on the mimickers what we are really trying to think of in terms of what constitutes a real, true lymphovascular invasion event. So we have four criteria here, and the first 2 are the ones that we talk about as the definitive or strict criteria because there's evidence of active invasion, active something going on that says this is a true invasion event. So the first one is if you actually see those tumor cells invade through the wall and through the vessel endothelium to be within the vascular space. So that's definitive proof 1 there. Another one would be that there's a reaction to some tumor cells within inside the vessel. So there's a thrombus attached to it. So that's kind of the 2 definitive criteria. The other 2 criteria is a little softer. So that would be neoplastic cells within a defined space that is lined by lymphatic or blood vascular endothelium. And the final one of those soft measures would be that you see neoplastic cells in a structure, but then you subsequently confirm that that structure is lined by some blood vessels or lymphatics based on immunohistochemical markers. So next. So in this case, you can see that these are 2 great examples of criteria 1 and 2. So one is we have the definitive invasion of tumors within and through a vascular wall, and then into the vascular space on the left-hand side. And on the right-hand side, we have a whole bunch of tumor cells, but you can see that there's clearly a reaction to that, which is the fibrin reaction to the tumor cells within the vessel. So those are the 2 very strict criteria. If you see that, then you can be pretty confident that's a true lymphovascular invasion event. Next, of those softer criteria, okay, I just see tumor cells within some sort of vascular space. So if you see a clear endothelial lining either on a vessel wall or lymphatic vessel, then that can be pretty good. If you don't see that until you maybe do IHC, then here's just a list of those IHC markers that you could possibly use to help define that as well. Next.
If I could make a note, there was a recent publication that showed, at least in one study, that PROX1 was used in dogs successfully.
Okay, great, perfect. All right. So moving on. So if you do then recognize a true lymphovascular event, then what report criteria do we use to report that observation? So next, you've already seen this slide, so we'll actually just keep moving on to the actual guideline, or the significance of these, and then the guidelines. So for the significance of this, why is this important to distinguish between a true versus a mimic event? Really, depending on what we're talking about, there are certain studies in humans, particularly thyroid studies, where depending on what type of tumor, they can have different outcomes. So you can see that there's a clear distinction between how often we see lymphovascular events with papillary thyroid carcinomas, but when you talk about of these, how do they behave? You can see that, hey, guess what? The Nishida study, only 8% of them had distant metastasis proved otherwise, in that study. With the other study with Mead and Aza, we can see that they looked at 4,000 tumors. Of those, only 3% of those fulfilled the strict criteria, and of those, 35 developed distant metastasis. So you can see that there is a proven correlation there when we can say this is a strict LVI event that we recognize, and it has some significant clinical outcomes. Next. Here's some more examples. So in this case, with more human thyroid carcinomas, we do know that papillary carcinomas will preferentially invade lymphatics, and then they will spread to lymph nodes, local lymph nodes, but they don't seem to progress or met beyond that. Whereas you have follicular carcinomas, they will preferentially invade blood vessels and then be associated with distant metastasis. So these are the type of dimensions that we'd like to kind of figure out. Does this actually happen in animals too? We suspect it probably does, but we don't have enough information and studies to actually prove that right now. With breast and colorectal carcinomas, very similar differences, right? Hey, we've got tumors with blood vascular invasion, and they have more distant metastases and seem to be more aggressive biologically. And there are some tumors that only display lymphatic invasion, and guess what? They spread to local lymph nodes, but don't seem to be really invading to into the vasculature, into the vascular system, and they don't seem to be as aggressive. So, it kind of helps us really define what those two things are. Next. There are other things that in humans that they will record. So, for example, when they talk about a TID scoring for lymphovascular invasion, they are talking about whether, hey, do you see it at all? That's absent. If you see it, is it in less than 4 foci? So that's sparse. And if it's greater than 4 foci, that's abundant. So that's kind of the dimensions of how they do their TID scoring. And you'll see that we've tried to replicate that in the reporting guidelines. They also have a few more dimensions that they measure or parameters. So they really actually even define it between intratumoral versus peritumoral lymphovascular density. So density of vasculars within the tumors and outside the tumors matters, and also whether the event happens within the tumor versus outside the tumor. There are other things that, of the things that we've measured so far in animal studies, we've only kind of done other things with microvascular density, and there's only been very limited studies trying to correlate the association between lymphovascular evasion and microvascular density. Next. So here are the guidelines. You can see the full guidelines also on the website. But when we talk about lymphovascular invasion, we do want to say, is it present? If it is, then there's those 4 criteria that you can tick mark. So did we see it through with the strict criteria, or was it more softer criteria? There is a box that you can check, which is equivocal versus not identified as well. If you do see LVI, then in terms of trying to figure out how much to quantify it, we have them categorized as few, moderate to many, and that's basically less than 5, 5 to 10, and greater than 10, respectively. We do want to also think that it's useful to note down what type of vessel was invaded. So was there a muscular wall evident or not? And then if you can distinguish it and the sample is okay for it, then can you also track whether it's the event occurring within the tumor versus outside the tumor? All right, next.
You want me to?
Yeah.
So one of the questions that we have is what the significance of lymphovascular invasion is in animals. We have this canon that lymphovascular invasion is important and means that this could potentially metastasize, as we're taught through Robbins when you're looking through those chapters and studying for your boards. However, what happens when it's not significant? And so one of the things that we need to investigate, that was investigated for benign extramedullary plasmacytomas, was lymphovascular invasion from those tumors. And so here you can see this beautiful embolus here within a vascular space, and over here as well within a vascular space identified by factor VIII as a vascular space, a vessel wall. And out of plasmacytomas, as Don mentioned earlier this morning, 16% had lymphovascular invasion. I've seen this in my own cases. And out of those tumors, there was no association with outcome. And so when is LVI significant versus when it's not? It looks like we have enough evidence to show that with cutaneous extramedullary plasmacytomas, it's not significant, but is it significant or not significant in other cases? And so keeping an eye out for this is critical because we just don't know. And then similar to the prior presentation, I had a little quiz to have us think about where does this fall on it? And these are just examples from my cases. Some of them I even had questions on. So I'll probably check the time, and we have just a little bit of time. So I'll spend about 30 seconds here. This is a case from a dog with mammary adenosquamous carcinoma. Is this lymphovascular invasion or not? And what category would you put for it? So this, for me, is a 2-for-1. On the left, I call this lymphovascular invasion because it's in a space lined by an endothelial cell. There's even erythrocytes. It's attached on the vascular wall and has organized fibrosis and inflammatory cells admixed with this. If it weren't attached to the vessel, I think I would have called this a pseudo-vascular invasion, some sort of floater, because of those inflammatory cells. On the right, I interpreted these as potentially just inflammatory cells, macrophages. So the next case is a mast cell tumor in a dog. I struggled with this back and forth. It is attached by a wall, but the cells are lined by endothelium all the way going around it. So I categorize this as pseudo-vascular invasion, impingement, so a mimicker in a space. This is a mammary adenocarcinoma in a dog. And on the left, this is a microcysta mimicker because it's lined by epithelial cells. There's a little nodular projection there. On the right, I call this a criterion 3. It's in a space within a vascular wall, but doesn't have thrombus or invasion. And then finally, this was a case I had trouble with. This is a melanoma in a dog, cutaneous. And the reason why I had trouble with this, and this has been identified in some of the studies, is that it looks like it would be an endothelial line space, but the cells are pigmented. And so I think if I had all the power in the world, I would do immunohistochemistry on this to try to confirm whether or not this is a vascular space. So, Richard, did you want to take this or make it?
Yeah, sorry, struggling to get off mute there. Yeah, so we know that the initial criteria and the discussion on the document on the website, it's just our initial first pass. So we hope that as we all start looking into this and reporting it in more standard fashion, that we may need to pivot, add things, remove things from those criteria, but we just need to start somewhere. So this is our first attempt at getting that. So we do know that maybe potential avenues for further refinement would be things like, how do we correlate what we see with outcome? And then is there any usefulness in creating some scoring system? And then, really, does it, do we need to always have strict criteria, or can we relax some restrictions, that sort of thing? Other things that we can talk about, which would be very useful based on the human side of things, is there a difference between vascular versus lymphatic? Are we doing lymphovascular invasion a disservice by just saying lymphovascular, and maybe it's better off to separate them out, into their own categories? So vascular invasion versus lymphatic invasion, and how does that correlate with outcomes? Also, the big thing that seems to be a really, one great avenue for us to pursue is what happens within versus outside the tumor for lymphovascular event, and how does that correlate with outcome. And then also a whole bunch of things about vessel or lymphatic microvessel or lymphatic vessel density and how that's associated with lymphovascular invasion and also separately with outcome. There's also a whole other dimension of exploring lymphovascular invasion. And so we're talking about things that we can't do as pathologists, but certainly our clinical brethren can do. So we can talk about things like scintigraphy, sentinel lymphatic and lymph node assessments, antibody-based techniques, that sort of thing. So there's a lot of things we can talk about. And there's even things like, we were talking about background about, can coagulation happen in lymphatic vessels? Can we see thrombi in lymphatic vessels? And the whole point is that maybe, I don't know, has anybody investigated? So the whole point is that there's a whole world out there for us to investigate on this dimension. And, we're just excited to see how everybody can contribute to this space. So I think that's all we have. So I think
just to add to that, we don't know if we don't start recording it. And so this has to be what I think we should be doing for everything that we start publishing. If we don't record it, then it didn't happen.
Great. And so, yeah, I'd like to thank Davis-Thompson Foundation for hosting this, ACVP, obviously everybody who worked on this on the VCGP side of things, and all these great folks who have provided images. So thank you. And there's a reading list at the end as well.